Welcome to the SCR Connections December webinar. Thank you, all of you, for joining us. It is my pleasure to introduce our two guest speakers today, Alison Caballero and Chris Trudeau of the University of Arkansas for Medical Sciences Center for Health Literacy. We're so excited to have both of them with us this morning. I'll start off with Alison. Alison is the Director of Programs and Services at the UAMS Center for Health Literacy. She leads the team of expert staff who make health information easy to understand through training, plain language assessment and editing services, health education materials development, and field testing. Previously, Alison directed patient education efforts at UAMS and secured major philanthropic gifts for the state's only children's hospital. Alison is joined today by Chris Trudeau, who is an associate professor in the University of Arkansas for Medical Sciences Center for Health Literacy and also holds a dual appointment with the Faculty of Law at the University of Arkansas Little Rock Bowen School of Law. He is an internationally recognized expert on health literacy, plain language, and informed consent. He has spoken for the FDA, the CDC, and many health systems. He specializes in developing clear, health-literate communication that both engages patients and complies with healthcare regulations. I'm now going to go ahead and pass the moderator privileges over to Chris and Alison and let them get started. Good morning.
Good morning. Thanks for having us. I just wanted to say that I just moved to UAMS about 6 months ago, and I was up in Michigan at Western Michigan University, and they have a newer medical school, and the librarians there were so helpful that I've really always been a fan of medical librarians. I always say these things, that if you give me a great medical librarian, a family practitioner who gets health literacy, we can change the world. So I really appreciate you all being here.
And Chris has come to a great place to kind of use that fondness of medical librarians. We have a fantastic medical library team here at UAMS, and we have the privilege of doing quite a bit of work with them and always look forward to the opportunity to get to do that and continue to learn from them and hopefully to grow together as we do things for patients. So.
All right, great. Well, let's get into the talk now. I've given versions of this talk in many ways, in many places. But one of the things I like to start with is really what our goals are. Our goals are really to kind of arm you with the tools to be advocates for health literacy within your organizations. Because again, I find that this a top-down approach works the best, but often you need a bottom-up approach as well. So if we work on the on the executives and the leaders making decisions, and then we have a lot of folks in the organization, and we just kind of saturate health literacy and clear communication throughout the organization, then this really helps promote change. So that's really one of our goals for today. So we have no relevant financial interest to disclose other than just that we work at UAMS. So what are we going to talk about today? Well, a little bit on the importance of health literacy for those that that may not be as familiar with health literacy as others on the call, but really kind of our take on some of the things that really help catch people's mind, or catch people's attention for why health literacy matters within an organization. And then I will talk about the business and regulatory cases for health literacy, which is something I don't think we hear enough about. We know that it's good for patients, but it can also be good for us on an organizational level. And then Alison will take over again and talk more about the tips to help you advocate for health literacy within your organization.
And like Chris said, or actually like our host said in the beginning, we really encourage questions throughout. So if there's something that you want to make sure that one of us addresses during the call, if you would just put that right in the chat box, and we'll be monitoring that and hopefully can get all your questions answered in our next little bit together. So we are going to spend a little bit of time just kind of recapping why health literacy matters to a healthcare institution. Many of you have probably written part of the book on this and could sing this song from the mountaintops, but we do want to go ahead and make sure that everybody has kind of a firm foundation of understanding how these things impact the work that you do. So quick little poll question, and we won't ask you to actively answer that, but just look at this list of factors that are likely to impact an individual's health status. And think about, what you know about each of them. Obviously, they all impact people's health, but which one do you think is the most important? And you don't have to answer that in the chat. Just think to yourself or with the group that you're there. So it's probably not a surprise to most of you, but maybe to some of you, that literacy skills are really the biggest predictor of an individual's health status. And so I think that's a really important piece of information to be armed with as you serve as an advocate, and we've tried to include all of our sources for all these facts down at the bottom of the slides. But that's one that I think gets a lot of people's attention. It does surprise some people that aren't invested in literacy-type work on a daily basis. So you can see there that, the people who report being in poor health, they know they're in poor health. Those are also the people that tend to have lower health literacy. So we also know that it's a problem nationwide, and this study hasn't been done in many years, and I hope that it can be repeated sometime in the near future. But if you look at the results from the National Assessment of Adult Literacy, you can see that we really tend to struggle as a society with health information. So you've got the different categories there, and for someone to really be named proficient in their health literacy skills, they really have to know a lot and be able to do a lot to help themselves. And if you look at the other end of the spectrum at below basic, 14% of the population really couldn't get past just circling a date on an appointment slip. So there's a lot to be said about that, and the bottom line is that really only about 1 out of 10 people have all of the skills. So when you hear people say things like, well, we're in an affluent community, so I think most of our people understand health information fairly well, that's actually probably not the case. And you can dig a little bit deeper in the survey results if you want to do that online, and you can kind of break this down, and you can look at this across demographic variables and really further drive home the point that even people with high income levels and high levels of education do tend to struggle with health information. And it really makes a lot of sense if you think about it. I'm sure you can think about a time when you've been to the doctor yourself and you've left and thought, I really have no idea what just happened in there. And it's not because you don't read well. It's not because you don't have some exposure to health care, but it's because you were sick, you didn't feel well, perhaps you were stressed out about the well-being of yourself or your loved one. So a lot of factors come into play there, but the bottom line is that a lot of people struggle, so it is a problem worth addressing. We do know that there are some groups that are at higher risk, but again, we can't make those generalities and assume that if someone falls outside of these high-risk groups that they don't struggle at all, because we know that's not the case. But it's not surprising, given the earlier statistic about health status and its relationship with health literacy, that the people who tend to have poor health status, and those listed here, the older adults, racial and ethnic minorities, and folks that do have lower income and educational levels, also tend to be more at risk for struggling with health information. So this is a study that looked at a couple of really large groups of patients in large public hospitals, and this is really pretty scary, that the majority of them really didn't even understand, I'm skipping around a bit, but didn't understand their rights and responsibilities section on a Medicaid application. 6 out of 10 did not understand a standard informed consent form. Patients complete a consent form every time they go to the doctor. When you sign in, you write your name down on that sheet, you get your updated HIPAA form, and maybe you sign off on that, but you almost always sign off on consent to treat, whether it's for a child's outpatient visit or a surgical procedure. So some pretty high stakes there.
So I like those stats because they kind of help, make the case that we all tend to think about from a healthcare perspective. The patient's case, we need to do the best, for patient-centered care and just to treat our patients. But what really kind of, again, grabs the attention of those at the higher levels are not only that emotional case for health literacy, which is what I call kind of the patient case, but also kind of the logical case for health literacy, which is really, to me, the business and legal case for health literacy. And the legal case for health literacy is something that that pretty much only I talk about because you know, I'm one of these strange ducks that are, you know, as a lawyer, but also really cares about patients, and so I like to try and mix the worlds together. But anyhow, so let's talk a little bit about some of this that you may not have heard before. But if you think about any avoidable problems in the health setting, you know, from hospital readmissions rates to medical errors to patient dissatisfaction, or how to even navigate your health insurance, they're all related to low health literacy or poor organizational communication skills. You know, so almost any metric that your institution is thinking about can be linked back to communication in some way. Now, from a business standpoint, I really love this study that Accenture did in 2015. It's a longer study, and I put the link on there for you, so if you have the slides and you're interested in kind of looking at some of the specifics of the study, you can do so. But these are two things that I think are really important for our purposes. But basically, you know, it suggested that a superior customer experience doesn't just strengthen patient engagement, it also correlates to 50% higher hospital margins. So when I've shown that in the past to hospital leaders, you know, if they're on their phones or on their iPads or whatever it is, they tend to look up because of, you know, in these days of trying to increase revenue with, you know, without getting, you know, the reimbursement rates as high as they once were, this is something that matters. And also, again, from this study, they found that a hospital system earning $2 billion in revenue would have to cut 460 jobs, assuming, you know, basically salary with benefits of $100,000, to achieve the same 2.3% margin benefit that improving the customer experience might bring through revenue growth. So again, so all of this clear communication is related to the consumer experience, and it relates to higher margins and hopefully the case to change minds.
And I just want to jump in for 1 second and say, you know, all of your institutions likely have a growing enterprise in patient experience, or some may call it a group focused on patient and family-centered care. But in my experience, one of the four main tenets, core concepts of patient family-centered care is one that's often overlooked, and it's information sharing. And hospitals will say, oh, well, yeah, we give patients information all the time. But it's that experience that Chris talked about it being meaningful and actionable information that can really make the difference for patients. And I think that's what that core concept of patient family-centered care is really intended to be all about.
All right, so another again, a fairly recent study by the SCAN Foundation. And again, this focused on the patient-centered care that Alison was talking about. But I thought these two quotes, again, from the longer study, which you can find at the link below, said this, that patient-centered care results in a greater sense of empowerment, a focus on wellness and quality of life, and a better care experience. But what's interesting is this next sentence. There's also evidence that it improves the job satisfaction of the healthcare providers. So if we're talking about the quadruple aim and provider satisfaction being the fourth prong of the quadruple aim, moving from the triple aim, there's evidence that patient-centered care helps on that front as well. And then again, the second quote kind of relates more to as we move to this value-based payment system, there's a lot of evidence suggesting that this will help as well. Patient-centered care will help reduce costs and readmissions rates and those type of things as well. So the business case is really in those metrics. But there's a major legal and regulatory case that I think we tend to miss in the health literacy world, and that's kind of what I want to talk about now. But if you think about all of the various policy perspectives, I'll kind of go through everything in this section, from policy perspectives to legal regulations to from federal regulations and then state regulations as well. But one of the HHS's strategic goals from a few years ago was to engage individuals and families and partners in their care, use clear and productive communication strategies, improving the experience for caregivers, integrating health literacy principles, and promoting patient self-management. This wasn't goal number 7, this was goal number 1, from the HHS's strategic plan. And you can find similar things like this in the CDC and FDA regulations as well. And in fact, HHS has a new draft strategic plan that was just released, I want to say about a month ago. So it's just a draft. It could change, but there were many things that kind of support what we're talking about here is consumer understanding of cost of care. That's one of HHS's goal. But in order to understand the cost of care, HHS suggests in this draft plan that they need to support health literacy tools and partner efforts to promote an understanding of health costs and terminology so that consumers can choose the most appropriate, affordable health plan that meets their health needs. And then also, I mean, there's literally 4 or 5 of these, but I just chose 2. The other goal is to ensure people have better information so they can make better decisions. Again, so that's really what you all do as librarians. You're helping people have better information. And the HHS supports what you do. To create support programs and build partnership with organizations that build the health literacy skills of disadvantaged and at-risk populations and promote proven methods of checking understanding. So this is, again, this is about ideal when you're trying to advocate for health literacy. So thinking about macro, which is the Medicare authorization or reauthorization or Medicare Authorization and CHIP Reauthorization Act. The final rule provides incentive payments for a lot of improvement activities that relate to clear health communication and health literacy. For example, you look at the second bullet, one of the specific initial improvement goals in the final rule is to engage patients, families, and caregivers in developing a plan of care and prioritizing their goals for action, which is documented in the EMR. So again, you can't do this. You can't engage patients, families, and caregivers in developing this plan of care if you don't have clear health literate communication. CMS's conditions of participation. Often there's lots of them, but one that's really that near and dear to my heart is informed consent. But one of the tags in these long conditions of participation says this: that informed consent requires that a patient have a full understanding of that to which he or she has consented. An authorization from a patient who does not understand what he or she is consenting to is not informed consent. So again, you have to weave in health literacy into these consent procedures and processes in order to comply with the CMS's conditions of participation.
And Chris, wouldn't you say that, since many of our listeners today are part of academic institutions, that the same applies in the research world when it comes to consent for research?
Oh, absolutely. Yeah, there's a new common rule that's going to go into effect in January of 2018. It actually may get pushed off. The effective date might get pushed off another year, but it's going to be implemented soon. That really focuses a lot on updating the common rule to focus on that patient understanding. So from a research perspective, from a clinical perspective, informed consent is a huge area where health literacy can make an impact. And the Joint Commission has said this 10 years ago, in fact, and this is kind of near and dear to my heart as a lawyer, but as a plain language lawyer, this is important for me. Informed consent forms that are written by lawyers for lawyers do not increase the knowledge of those who, with their signature, are committing to allow the performance of treatments and procedures that may be associated with significant risk. The typical informed consent form is unreadable for any level of reader, and we find that a lot when we do readability studies of informed consent forms, is that they're written at a 12th grade or higher level. Some might be lower, but you do an internet search for informed consent for colonoscopy, for example, and you'll find some horrible ones. Again, so from a long-term care facilities, this is something that matters in that regard as well. So again, CMS's new conditions of participation for long-term care facilities that just came out, I believe it was this past January. The resident has the right to receive notices orally, meaning spoken, or in writing, including Braille, in a format and language that he or she understands. So I'm seeing a big trend in these new regulations that are coming out that focuses more on patient understanding, which you can't have without health literacy. And the guidance to that actual section says this: in a language that the resident understands is defined as communication of information concerning rights and responsibilities that is clear and understandable to each resident. So again, there's a lot of regulatory support for what it is we're trying to do. And so that's kind of what I want you to understand here today. And again, if you're looking for, finding the actual printed out support, you can see it in the link below. Home health care organizations, again, a new CMS rule requires a patient's rights notice. And that notice needs to be written in a language and manner that patients can understand. So again, you're seeing CMS over and over again in the various conditions of participation that it updates, requiring or understanding that patients haven't understood these in the past and requiring that they do so with these new notices. And so this is really where the title, The Sword and Shield of Health Literacy, comes into play, is the liability risk for poor health communication is very high. 4 of the top 10 reasons for malpractice have to do with communication or poor health communication, either no informed consent at all, or informed refusal, or weak patient education, or communication problems within with doctors to patients, or with doctors among other doctors. So about 70% in another study has said, which is not cited here, of malpractice claims relate to some breakdown in communication. And so that is very telling. And so that's why I say that managing risk and liability is why health literacy is a sword and a shield. Health literacy is a sword because we see that the regulations now and require that things be clear. And so organizations that don't adopt health literacy and don't become health literate are opening the door for claims that they're not following the regulations, that they don't care about patients. Basically, they're not only liability but also patient dissatisfaction. But health literacy is a shield as well, because now that we have all this data, we have a lot of data showing how important this is to outcomes. And we have these regulations saying that things need to be clear. If you are following these things, you are meeting the gold standard. And so again, if your organization is embracing health literacy, they're putting the shield of protection from a liability standpoint around it, which helps, again, reduce some claims. Now, from a state perspective, we're starting to see provisions mandating clear communication are becoming a feature of state regulations. Some of you may be familiar with CARE Acts. Basically, they might have different names in your state, like Arkansas has the Arkansas Lay Caregiver Act, but the AHRQ has been helping to pass these in numerous states, and I think there's 14 or 15 states that have passed CARE Acts. Michigan's CARE Act, where I came from again, basically says this: training or instructions provided to a designated caregiver shall be provided in non-technical language and in a culturally competent manner. So again, that requires clear communication. In Arkansas's Lay Caregiver Act, where we are now, again, requires that the hospital needs to provide a caregiver with a discharge plan that describes any aftercare needs of the patient, and the hospital needs to educate the caregiver concerning the aftercare of the patient in a manner that is consistent with current accepted practices and based on the needs of the caregiver. So we know what the current accepted practices are for clear communication. So again, that's more support, at least in our state. But there's many other states that have that. Delaware has just a fantastic one that actually mentions the word health literacy in it. But they're all basically the same thing, and they require clear communication. So there's a lot of support, not only from a patient satisfaction side of things, but also from a business and regulatory side of things, to help you advocate for this. But then the next part is really, how do you even go about integrating health literacy throughout an organization? That's such a tough concept to think about, we thought we'd provide you with some tips.
Yeah, and you guys are often looked to, I know the medical library folks on the call are often looked to as the go-to people when it comes to consumer health information. And so I think that you're well positioned and to be advocates within your healthcare organizations, and I'm really glad that this became the focus for today's call. Hopefully we can give you some things that you can think about, either leading yourself or just about having conversations about with other leaders within your institution. There's a great toolkit that goes along with this from the AHRQ, but this is just a really brief introduction to kind of what a health literate organization looks like. So if you get the right people's attention and they agree with you that, when health literacy is not well managed, there are problems, not only for patients, but for the institutions themselves. These are some things that an organization can strive for, and I think that there's a lot here. I think it would take all of us a lifetime to get to this, but I think that there are some easy wins built in, and we'll talk about some of these as we go.
And I really do recommend, if you're interested in this more, looking at that AHRQ Toolkit, because they kind of break down each one a little bit more. But again, and so you get a lot of advocacy pieces in this as well. Not only how do you integrate it, but like, for example, number 2 integrates into metrics for safety and quality. They talk a little bit more about how to do that, which then you can use as kind of fodder to make the case, you know, to the patient safety folks in your organization. So,
absolutely. The toolkit's got everything from assessments to how-tos, so it's a really, really good resource. I think if you just Google AHRQ Health Literacy Toolkit, you should get to those great tools that Chris is talking about. But just to walk through a few of these, you know, a good strategy for any mission within your organization is to really make it clear that your mission, your structure, your operations support whatever that strategy is. So with the case for health literacy, you want to see that leadership is really advocating for that, that somehow health literacy and patient understanding and good patient-provider communication is integrated into the written mission of your organization. And a little beyond that, into your structure, do you have people whose job it is to pay attention to this and who have some authority to make sure that as many of the things on this list, you know, as possible are happening within your organization? And then operations, obviously things, you know, take resources. Any initiative takes resources. And so, you know, having the right tools in place, the right people in place to implement these is going to be key. So the second one with regard to metrics for patient safety and QI, there are so many varying strategies on different campuses focused on patient safety and quality improvement, but many of them, if you just look at your, you know, if you were to ask your quality improvement coordinator, who would be a great person for you to meet with after this call, by the way, if you were to go and meet with that person and say, tell me about your top, you know, 10 quality initiatives on campus today, I can almost guarantee you that many of them will have metrics that are built around patient behaviors. And so you can take something like falls. Many hospitals are probably looking at safety programs to reduce falls in their inpatient units. There's some patient education required in order for that to happen. You can put a fall mat under a patient's bed. You can put alarms, you know, on the patient's bed when they try to get up alone that sound off at the nurse's station. But you will be much better served if you have a comprehensive falls prevention program that includes some patient and caregiver education that explains to those folks why a person may be at risk for falls and what they can do to keep themselves safe. And if you communicate with them in a way that engages them as a partner, you know, this is how you're at risk, this is why you're at risk, and we really want your partnership to help keep you safe. But talk to your safety and quality folks and look at what their metrics are, look at what they're measuring to facilitate patient safety, and see where health communication with patients and families is already on that list, and then look for places where it's not on that list and where it might ought to be.
And I think numbers 7 and 8 really fit within, you know, a lot of your roles too as librarians. Ensure easy access to info services, design easy-to-use materials and e-tools. We've partnered with, and maybe Alison can mention this before, we've partnered with our library to help do that. And I don't think you can truly, as a health system, create easy-to-use and easy-to-access info without collaborating with the library. So, Alison, maybe you want to mention that?
Yeah, I mean, what a great resource, and certainly in the academic settings, there are, you know, medical libraries on site, and we're fortunate in Arkansas to have a clinical enterprise that spans our entire state. We have a central campus here in the central part of our state, but we've also got regional campuses scattered around the state, and each of those has a direct link with our medical library here at the main campus, and that's an incredible resource, not only for the patients and families, but for the clinicians as well. And we'll talk a little bit more about design of easy-to-use materials in a few minutes. Get through just a few more of these. So workforce, we'll talk a little bit more specifically in a few minutes about some of the training, you know, that we would recommend at a minimum. But this is something that, again, we're fortunate here at UAMS to be thinking about our future workforce as we train individuals to serve patients as physicians, nurses, pharmacists, public health professionals, and so on. Our health literacy training is integrated into curricula across all of those colleges, and we're fortunate for that and would certainly advocate for you to look into that. And we'll move on and talk about a few more of these in detail.
All right, here's some specific tips now, kind of moving away from the 10 attributes, but into things that we found that can be really helpful. But again, just to get you started, because, you know, it's kind of hard to think about how do we change the entire organization, but if you break it down into smaller chunks, then it's, or smaller projects, it can be actionable.
So everyone talks about universal precautions when it comes to infection control, you know, use of personal protective equipment and treating everyone essentially as though they might have an infectious disease that could impact other patients or healthcare team members. And so we really advocate for a similar universal approach when it comes to health communication. And like our earlier information, you know, let us know, you just can't tell by looking at someone if they have low health literacy. They may not fall into one of those, what we would consider a high-risk group. Anyone can struggle with health literacy at any time. They can struggle on a daily basis, or they can struggle when the demands that we place on them in the healthcare system just in that moment exceed their ability to respond and to be good health communicators as recipients of information and as senders of information. I keep trying to advance this slide the wrong way. Chris is helping me here. So we talked a little bit earlier about the patient-family centered care enterprise that many of your institutions likely have in place. It's a growing and a really exciting body of work. And one of the key features of many of those initiatives is the use of patient advisors in various capacities. And I've kind of have the term patient advisor council here loosely because it looks a little bit different in every organization. But if you think about those groups, I think a lot of times people are not sure exactly how to maximize the use of patient advisory councils. And again, I feel blessed to be here at UAMS where we have a really thriving enterprise in that, and we have councils, multiple councils across different service lines and clinical practice settings. And we have the chance to work with them on a regular basis. One of the things that they do is to look at patient materials, written materials that are going to be provided to patients in various clinical outlets. And so we started to work with them to have them review some things that we've created and to give them some strategies on how to work with those groups most effectively to get really good feedback on written content. Like any focus group, you know, looking at field testing of written health information follows some standard protocols in terms of having a good trained facilitator and having a moderator's guide, but we've found some interesting ways of asking people to look at information. In fact, there's an article that we put out not long ago on our process. It's called Stoplight Coding, and so we put written information in front of patient-family advisory councils and other groups, and we kind of give them some steps on how to mark those up. So I'll just give you an example that we have them mark up things in red that they don't understand. So something that we missed as far as technical jargon that makes its way to a patient-facing document, they'll find it. Then they also get to tell us if there's something, they use yellow to mark up things that maybe they understood well, but they had to read it a second time. It didn't make sense the first time they read it. And because we try to really incorporate individuals with low health literacy in our field testing processes, those folks are not always the first ones to speak up. And so you may put a written document in front of a patient or community volunteer like that, and they just, you know, you might find that they just nod and say, yep, everything looks fine. It's easy to read. I understood it all. But if you give them an opportunity to tell you what they think other people might not understand, it's amazing what they come up with. So again, they first mark up in things in red that they don't understand, but then they have a chance to mark things in yellow to say, well, I understood it perfectly, but I don't think that my neighbor would. And that's a really important thing to do when working with people that tend to struggle with health information.
And just acknowledging the question in the chat box, yes, these slides will be made available. I'm not sure where. I know that Sarah will talk about that, remind you about that after the presentation again, but we are very comfortable giving folks our slides, and so that's the point, so you can have access to this.
Yeah, so just to kind of wrap up this slide, I would just encourage you that, you know, if you have patient-family advisory councils, use them to help you guide what health communication ought to look like. We can give you best practices, but I'll tell you that when we get patients, families, community members together, especially those with inadequate health literacy, they teach us something every time we do it. And so if you've got those councils, reach out to the people that manage those and say, we've got some information that we want people to look at, and could your councils help us out with that? In advance.
I'm just reading a question here. Do you know of anyone who has created a plain language informed consent for blood products, blood transfusions? That's a really good question. I have created some for a lot of various things from infusion pumps to colonoscopies, but I have not done one for that. But yeah, so I don't, it'd be interesting if you do a search for things that are out there on the internet, you're likely to find horrible ones. That's, I'm teaching a drafting class next term, and one of my first assignments is to try and find a clear contract and to try and find one that's not clear. And I said trying to find the one that's clear will be very difficult. So I'm not sure. But then there's another question Alison will take here.
Yeah, I want to answer this one since it's related to the slide we just left. How do you recruit or identify low health literacy members of patient advisory councils without offending them? That's a great question. And so a couple of ways here at UAMS, and I think one of our biggest opportunities is that we have started implementing, our clinical enterprise has started implementing a validated health literacy screening tool across the enterprise, and it started out with one service line and has grown to most, if not all of them at this point, but it's actually just a single question screener. And so we have, patient data that's rich with that information. And so while we can't tap into that when our patient family advisory groups can't really tap into that when they do recruitment, we're often able to tap into that if we're working on a large kind of institution-wide quality improvement initiative, or if we have a research protocol that's been approved, we can ask our, data warehouse managers for, lists of patients who have failed that health literacy screening. And so that's one way that we've been able to identify some of those individuals. And, perhaps they come to one focus group and we say, you've provided a lot of great feedback, and would you be interested in us calling you again? And if so, then they stay on our list. For people that come to our field testing episodes that the Center for Health Literacy hosts, a lot of them we don't know their health literacy status because we didn't find a good way so far to not offend, but to even get that kind of information over the phone. There was just this inherent desire over the phone when we asked that screening question for people to say, yeah, I'm really good at that. I really understand health information very well. I want to help you out. I want the $25 gift card. So we are not doing that. We are doing a longer, it's called Newest Vital Sign, just a longer health literacy screening instrument actually in our focus groups. And we just pull people aside whenever they arrive and we say, this is your first time here. This is an exercise that we do with all of our first timers. It helps us better understand how you as a group understand and respond to health information. So we always try to pitch it as, whenever we do that individual kind of testing, if you will, we do this with everyone. It's meant to help us better characterize the group.
And then a couple questions on are we able to share the health literacy tool. It's just a single question, and I'm trying to remember the exact wording of it right now. It was
the question is, how confident are you in filling out medical forms by yourself? And the author on that was Chew, C-H-E-W, but I'm happy to send that reference to our host after the call in hopes that they can share it with everyone.
And then the other, I see the question from before about your privacy officer, about rewording your notice of privacy practices. Very good. Yeah, I mean that's one of the reasons I'm here at UAMS to start doing that here as well, but not only within UAMS but outside for other folks as well, because people have not done a good job with that, and basically a lot of the health literacy advocates who aren't lawyers who have tried to do this in the past have been shot down by, like you said, your privacy officers or your legal counsel, because they kind of feel like, well, they might not be as well-versed in health literacy in plain language as others, and so if you aren't really well-versed, you just say, well, this is the way it is, and it's worked, and so it's fine. But that's kind of what my role in life is to clarify a lot of these notice of privacy practices. So I appreciate the question, but there's really not anything out there right now about that, on that.
And I think if we were to approach that, we would do it the way that we do most of our other plain language editing work for UAMS and for others, and that is, we make our best attempt to apply all of the best practices of plain language writing, but then we get to that patient family advisory council or to that field test group that we've assembled, and we ask for some patient feedback.
Yeah, one of the good things you can argue with your attorneys, by the way, I don't say argue, advocate with your attorneys if they give you pushback, is say, health literacy and the law are not mutually exclusive. You can create these win-wins. It's difficult because you still have to cover all of the different angles of the law, but you can certainly make it better than what it is. It may not be perfect, but it can be better. And once I kind of change their mindset into incremental change, instead of going from a 15th grade level down to a 6th grade level, you might not get there with some of the more complicated legal documents. But if you get it in that 8th grade level area, 9th grade perhaps, it's better than where it is, and so you're moving the needle in the right direction.
And that's a great segue into this slide. And Chris, I'm going to have you tackle this one because a lot of this brings up legal questions as well. And someone asked earlier about consent, and you touched on that as well. But I think that lends itself, too, to what happens when patient complaints come in the door, when medical errors happen, and how you communicate that information. So
right.
Well,
yeah, medical errors and consent and all of this is a huge area. It's its own talk. I mean, no doubt, because you've likely heard the statistics that medical errors are the 3rd leading cause of death of adults in the U.S. So there are a lot of medical errors, obviously, every year, and you can't prevent them all. But what I like to do, what I like to target from a health literacy standpoint, intervention standpoint, is let's get rid of the ones where people complain or see a lawyer because they feel like they haven't been heard or listened to. So the communication problem's one. And that is a big problem, obviously, is because if you can prevent people from going to see a lawyer in the first place by hearing them out, and kind of listening to them and kind of understanding, basically conflict resolution, techniques, then that can really help. And so one of the things I often advocate is another AHRQ toolkit called the CANDOR system, C-A-N-D-O-R, but it basically stands for something like communication and optimal resolution. That's something weird like that. But anyhow, they have a toolkit as well, and so that basically flips the script from deny and defend. Oh no, you have an issue. We can't talk to you about this. To let's embrace basically that there are going to be medical errors and there's going to be problems. So the way we deal with this matters in terms of lowering liability rates, and that's exactly what the AHRQ Toolkit, and they've implemented that at 13 or 14 hospitals in a program, and found that it really did reduce litigation costs as well. So, but part of that. CANDOR system doesn't talk about health literacy, so that's part of the problem in this is that you have to design the processes, the consent forms, the consent processes to facilitate this patient understanding, because then you're less likely to have those unexpected outcomes. If something happens to you that you didn't expect to happen, or recovery is more difficult than you expected, it's natural to think, hey, they didn't tell me this. This is not right. And so designing this complaint process, the consent process, in ways that people can easily understand and follow, that is very useful, I think.
Yeah, so we mentioned training a little bit earlier, and there's so much that you can do. But when you think about health literacy in the broader context of patient-provider communication, there's a lot we could and should teach both current and up-and-coming healthcare professionals about. But at a minimum, we would really have you advocate for the use of teach-back and for training all clinical personnel to use that. And so for those who aren't familiar, it's essentially a way for the provider to make sure that what they've said to the patient has been well understood and is actionable. And if you think about, why we communicate health information, a lot of it, outside of the legal and we have to tell people certain things, it's so that patients can act on it. There's something we want them to do or to not do to take care of themselves. And especially, with chronic disease, with newly diagnosed conditions, there tends to be a lot of that. And again, you can all put yourselves in a position where you've been in an office and been given a lot of instruction about what you need to do. I have my own example to share, but I won't. But at any rate, if a provider can say to the patient, gosh, I've just said a lot to you about what you need to do next between now and the next time you come back to see me. I know your husband's not here. If you have to go home and explain this to him, how would you do that? How would you explain that? I've told you a lot. Let's make sure that I've done a good job explaining that to you. And there are lots of great resources online for teach-back training, but it's definitely a skill that is not as thoroughly utilized as we would like to see.
Yeah, and that is the gold standard. There's a lot of organizations that do this, and I'm friends with a lot of them. We do. So I teach some of the teach-back training here within some of our health professions programs. The key is that everybody that interacts with patients should be trained in this. And the other thing I like to think about is when you're considering, vendors, consider health literacy. I mean, think about EMR vendors or, when you're outsourcing some of your patient education materials, you should think about that. I mean, that is a huge factor. For example, here's a screenshot of this is not where I am now, but where a screenshot of the EMR or the patient portal that I used to have. And this is not me. I'm not 5'8", I'm 6'4". But think about all of the burdens that we place on somebody with low health literacy. Think about the numeracy aspect. My weight is 85. This is, again, a patient portal. 85 kilograms. What is that? It's like 2-point-something times, we'll get you into pounds or something like that. And so it's got 85 kilograms, and then it's got pounds down in the middle. And then, what does a BSA mean? Here's my BMI. What do all those things mean? And this is on a patient portal. So that's another thing I like to kind of plant seeds for, because I don't think we tend to separate some of that, the vendors from this process, but they are critical to this process. So if you're still skeptical, or more importantly, if some of the leaders or decision makers are still skeptical, I always say shrink the change. The 3 stages of health literacy integration that I like to think about is you need system-based policy changes. But this system doesn't have to be organization-wide. It could just be in a specific unit or subunit where you're focusing, let's say, in the ER on reducing hospital readmissions, for example. So the policies, the goals you create, your vision or whatever, strategic planning can relate to that from an EMR standpoint. It doesn't have to be the whole institution-wide. Implementation then. Okay, so then that's the hard part sometimes, is thinking about, all right, well, how would we implement this in in a whole organization? It's hard to think about that. But if you break it down into the EMR, into the ER, and you're thinking about, reducing discharge or reducing the readmissions rates, then you can kind of think about, okay, how do we do it now, and what might be best here? And then I think the key, one of the things we haven't done as a field very well yet, but we're starting to move into that, is with outcome measurement. We've done a lot of research on the need for this, and there is some outcome measurement, on medications and medication adherence rates and those type of things. But I think any time you implement some plan, if you kind of have a baseline data and then you look at the change, that will really help kind of get the snowball rolling downhill. Look, this is how we've improved this in the ER. Why don't we try this, in this other area of the organization?
And I'll just add one last thing. I know that, the purpose of this call is really about the organizational climate and the strategies that organizations undertake. But I think, we all know health literacy is this two-sided issue, in that we can change what we do and the demands that we place, from the organizational level and the provider level, but there are also things we can do to help patients and consumers understand and improve their own health literacy. And so, be mindful of those as well, and I know that that's where library folks tend to really excel, but I think even some of these principles can be applied there. So when you think about the types of, subscriptions that you'll have to patient information, perhaps as a medical librarian, you get to weigh in on that, and you get to help the system decide what collections of health education materials are going to be made available through the clinical enterprise and even just through the library alone. You can certainly keep those things in mind.
That's great. Yeah, I mean, that's you really are on the front lines in many ways of improving or health literacy with actual patients and the people in need. So we do appreciate all the work you've done. So let's sum it up now. I know we're at 10 to the hour, and so we have some time for housekeeping and any other questions that you may have. But again, so the case for health literacy, is there. If there's tons of research on, the better health outcomes, the better patient satisfaction. But also some of the things hopefully you learned today is that we can also reduce the lower risk of litigation and have better compliance with the laws and regulations through health literacy. And so we can do this by thinking about system-based changes and then effectively implementing this and then measuring the outcomes, so that way we have support for the next project we want to do. So what questions, if any other questions that you may have? I know that many of you have been engaging with questions here, and I appreciate that a lot.
And it looks like the articles and other resources that we've mentioned, folks have already posted links to those, so whoever did that, thank you, we appreciate that.
Yes, very good. That's why we love librarians. You can find things and very quickly.
Very resourceful. There's a question in, how do you handle requests for health information in other languages? It can be very expensive to translate existing items, and many organizations don't have a budget for it. That's a great question. So, you know, as a Center for Health Literacy, our task right now and our positioning within our organization is that we help improve written health communications and that, you know, when it comes to written things, and that we create some new things for our clinical enterprise. And so often our role is to take things that already exist and to change those things into plain language. And so we talked about grade level readability earlier, and that's a piece of the puzzle. The rest of it has really to do with making sure that things are organized and formatted in a way that you know, is, you know, takes best practices into account, and ultimately so that the information can be actionable for the patients. After we do that, those things, you know, will go for Spanish translation, and we're fortunate here within our center to have a bilingual staff member who's also trained in plain language writing. And so she, you know, does those translations, but then she's got a process to go back and make sure that all of those plain language best practices are still there after the translation happens. And it is very difficult because it's rare to find people that are both bilingual and trained in plain language. And so we really try to partner with others on our campus who provide translation services and interpretation services and make ourselves available to kind of help them ensure that those Spanish level documents are in plain language. But I would say the biggest thing is to always start with, you know, we typically start with English to get that in plain language before we have anything be translated.
And then that's great. And then the next question: where can we find samples of patient-friendly informed consent forms? Unfortunately, they're a little hard to find because the ones I've done have been for clients, and you know, there's and so I can't really put a lot of them online. But you know, you will find some that are out there, unfortunately, but they're not as widespread as they should be. But that's, again, one of the reasons why I came here, is because now I have some dedicated support and time to create these things that are widely available instead of just more client-focused. So I hope to be having more and to have a better answer for you in the next year or so, and so you can kind of say, okay, here's some samples that are out there that we might be able to use. But I just haven't had the chance to create those that are publicly available just yet.
There's another question about federally qualified health centers and their use of patient family advisory councils, and that board members often are from the served community, and someone asking if anyone has used those particular councils to review written information that their institutions are providing. And so I'll pitch that out to the group, and because I don't know of any federally qualified health centers who are doing that right now. I just haven't heard about that. Doesn't mean it's not happening. I hope that it is, in fact. But certainly having that built-in family advisory or community advisory board is a good opportunity to review health information. But I would advocate for, you know, someone asked the question earlier, how do you make sure you get people on those groups who have low health literacy? You may not be able to, and that's when I would advocate for bringing some other people to the table for those selected opportunities.
Yeah, and another question: where can somebody find training on plain language? And there's a nice link to CMS, who offers training, and CDC also has some really good training modules that are online as well. Obviously, we offer it, you know, but we don't want to promote our services much here. We want to just educate you. But there's a lot of places to be trained, at least to get some of the basics, and then the nuances. I think you often have to learn by doing, or you can be in more of a you know, small group type training. But there's a lot of broad resources. CMS, CDC are the two that come to mind.
There's certainly some good kind of introductory courses available out there online, and we would encourage you to you know, kind of get that under your belt, and then think about some more interactive training that includes feedback from people who do that kind of work. Other questions?
All right, well, it looks like for the time being there aren't any more questions. If people do have more questions, they can feel free to send them to us, and we'll be happy to send them on to Alison and Chris for you. I just want to give a huge thank you to Chris and Alison. Thank you so much for this wonderful presentation. I'm so excited to have this in our arsenal now. It has been recorded. It will be posted online. I do ask all attendees if you would stick around for just a few more minutes. I'm going to end the recording, and then we'll move over into some of our final housekeeping. So again, thank you, Chris and Alison, and everyone, please stick around for a few more minutes.